afternoon, everyone. Welcome to Public Health Ontario, or PHO Rounds, for this afternoon. My name is Leanne McDonald. I'm a public health physician here at Public Health Ontario, and I have the pleasure of moderating today's session, which is on tuberculosis deisolation. So I will start with a few housekeeping items before we begin the talk. We have disabled the chat pod to limit distractions during the presentation, but do please go ahead and use the Q&A pod if you have questions, and then we will have a discussion and question period following the presentation. So yes, do please share your questions at any time in that Q&A pod. If you have any technical issues during the session, you can email capacitybuilding@oahpp.com. And on behalf of myself as the moderator of the session, my only disclosures are that I am employed at Public Health Ontario and am involved in CIHR-funded research. So before introducing Dr. Ryan Cooper, our leader for today's session, I do want to start with a brief land acknowledgement. We acknowledge that the land we are hosting the virtual education session on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 within the Mississaugas of the Credit. It's now my pleasure to introduce Dr. Ryan Cooper, our speaker for today's presentation. Dr. Cooper is an infectious disease physician, an associate professor at the University of Alberta. He's also the TB consultant for Alberta Health and medical director of the provincial TB program. And his major clinical interests include TB, HIV, viral hepatitis, and refugee health. Dr. Cooper completed a medical degree and specialty training at the University of Alberta and completed a master's in public health at the Johns Hopkins School of Public Health. So welcome, Dr. Cooper.
Thank you so much for the introduction, and also thank you so much for having me speak with you all today. I'm grateful for the opportunity to talk about tuberculosis, and I can see that there are literally hundreds of people logged on. So I'm really I'm tickled to see so many people interested in TB, which is an area of medicine I'm pretty passionate about myself. I also should start off just acknowledging that I'm speaking to you here, via the interwebs, but I'm in Alberta and I'm on Treaty 6 territory, the traditional homeland of the Cree, Dene, Métis, Blackfoot, and Nakota Sioux. I'm very grateful also for the excellent help with the technology that we've had to be able to speak with you today. Just yesterday, all of our healthcare internet and network went down, and we had to practice medicine without our electronic record. And it was shocking. Take my stethoscope, but not my EMR. We had a medical student had to write a consult on paper, and afterwards he's like, "What am I supposed to do with this piece of paper?" Because we had to do everything on paper. Anyway, I'm grateful that I'm able to chat with you guys by Zoom today. We're going to talk about TB infectiousness and the impact of treatment and when it's safe to de-isolate people. I should, by way of disclosure, I have no financial conflicts of interest or relevant disclosures. I will be speaking from about the Canadian TB standards, particularly the Appendix B, which I was an author in collaboration with others. I hope today to sort of explain that appendix and some of the new changes in de-isolation policy. My objectives for today is to describe the levels of evidence informing de-isolation of people on treatment for TB, as well as outline those new de-isolation guidelines. And I also hope to kind of take you through some of the policy discussions that we had at the national level during the creation of the TB standards and some of the pros and cons of this policy. And so you can kind of understand that some of the discussion that behind the guidance, some of the evidence behind it. We'll start with a real case. This is, this is a real case. I have altered some of the details slightly. And the photos and images are actually taken from previously published manuscripts. They are extremely representative, but they are a different patient, just to doubling sure. So this is a man from Northern Alberta. His past medical history is significant for smoking, tobacco. He also drinks alcohol in more of a binge pattern, mostly just weekends. He's otherwise healthy. He had a persistent cough for 3 months, intermittent fevers and weight loss, and had the a familiar story to TB practitioners. Cough did not improve with a course of amoxil. He then got a course of azithro, and truth be told, he also got a course of levofloxacin, which led only to transient improvement before his, but his cough eventually came back and would not go away. And so a chest radiograph was done in his local emergency room, and it showed the pattern to the right, which is highly suspicious for tuberculosis with the upper lobe involvement and the cavitation. And so he was admitted to a local hospital. Thankfully, TB was suspected right away. Sputum samples were submitted and came back 4+ visible acid-fast bacilli on the direct oromine-rhodamine stain. A PCR was positive for Mycobacterium tuberculosis complex. And in our setting, we use the Expert MTB platform. Because of the diagnosis of TB and because his local hospital did not have the infrastructure to facilitate airborne isolation, he was transported to Edmonton for treatment start, and so that he could be placed in a proper isolation room with negative pressure and an anteroom and high rates of air exchange, and where the exhaust was HEPA filtered. We started him on anti-tuberculosis therapy with standard regimen of INH, Rifampin, Pizidate, and ethambutol. He noted that by day 8, his fevers had resolved. His cough was starting to improve, but wasn't absolutely gone. He still had this less productive dry cough, but it was substantially better. It was one of the first things to improve on TB treatment, which is typical response. He also disclosed that he's feeling better, feeling stronger, getting out of bed. Unfortunately, as it happens, is typical, the phenotypic drug susceptibility test results were pending or were not available, and he was tolerating treatment. He was not having any nausea or obvious side effects. Follow-up sputum samples were still 4+ positive on direct smear. Then 4 weeks into treatment now, he's been on our TB isolation ward on the 5th floor of our hospital here in Edmonton. It's an area with 5 beds. There is no sort of access to the outside. They are kept, they're good isolation rooms and a little anteroom where they can walk around. And each of them has their own room, but it is not, it is not like the sanatoria of old where you can walk around these beautiful groomed grounds and gardens. It's unfortunately, it's still a hospital. So he's been there for 4 weeks. He's still smear positive on sputum samples. He's now about 1 or 2+ smear positive. We now have the phenotypic drug susceptibility testing results, and they're back, and they're fully susceptible. He's basically asymptomatic now. Maybe he has a little bit of a cough, really wants to go home, really wants to go back out to work. And he's like, at least get me out of this isolation room. And in fact, he called it like a jail. He was deemed, unfortunately, ineligible for home isolation. He came from a very crowded household with dynamic membership where visitors couldn't be controlled. There were lots of people and children staying over at his household, and it was felt that he could not go back to that setting unless he were deemed non-infectious. Now we're getting pressure from the bed managers. He's like, these COVID patients need an isolation room. Your guy looks ready to go home to me. Why don't you send him home? And so we asked, well, when can we send someone home? And at the time of this case, which was, I guess, just last year, 2020, 2022, early 2022, late 2021, we had to rely on the TB standard 7th edition from 2013, which is consistent with the American guidelines, which were published 2005, although they still operate under those guidelines. And that is that patients with smear-positive pulmonary tuberculosis should be kept under airborne precautions in an isolation room if they're in hospital, until there's a clinical evidence of improvement, adherence to at least 2 weeks of effective multi-drug therapy, and antimicrobial susceptibility results are known, and 3 consecutive negative AFB sputum smear. So we have to document that they're tolerating therapy, that it's proven susceptible isolate, and that they achieve smear conversion as defined by 3 consecutive negative AFB sputum smears. But anyone who's had experience in managing patients with TB, sputum smear conversion takes a very long time. Looking at a recent systematic review suggested that the average time to achieve sputum smear conversion is 37 days, so more than a month of being sputum smear positive. In Alberta, we find that less than 10% of smear converted within 2 weeks, and less than a quarter by 3 weeks. It also should be appreciated that even when patients have smear converted, they often remain sputum culture positive. So they're still excreting viable living bacteria in their sputum, or at least bacteria that can be cultivated in vitro. And on average, that's about a 6 weeks timeline. So even under current practice, we're still de-isolating people when they remain smear culture positive. But it takes a long time for sputum smear to convert. So a couple of questions I think are raised by this case and that I wanted to discuss today is, how soon after starting anti-TB therapy for pulmonary TB can we consider a patient no longer infectious? Does the sputum smear status, once they're on treatment, predict infectiousness? And do we really have to wait for this? Because it's a common experience for us that patients are clinically better before the sputum smear is converted, and there's a lot of bed pressures. There's a lot of pressure from the patient who's uncomfortable to de-isolate them. And so that's a question for today. And then we'll talk about once we've seen the evidence around sputum smear status predicting infectiousness, what are some of the implications for policy and when can we de-isolate? So I'd like to now just take a bit of a historical perspective on this. It is a fundamental piece of TB control in our population is identifying active infectious cases and placing them on TB treatment. This is a picture of Dr. Stiblo, who developed in the 70s the Stop TB approach to controlling TB globally. So this is identifying infectious cases and putting them on treatment. It is understood that the best way to stop spread of TB in the community is to get people on TB treatment, because once they're on treatment, we know that they become non-infectious. But just how quickly they become non-infectious after we start therapy is not known with 100% certainty. Going back a little bit to the 1990s, now at this point I was mostly wandering the halls of my high school and not a TB sanatorium, but I am told that prior to the 1990s, most practitioners would use something called the 2-week rule, which is that they would start TB therapy, and then after 2 weeks, they would de-isolate people and send them back to their homes or to their workplace. This was based on clinical experience, original guinea pig data, and some clinical trial data, which we'll touch base on momentarily. But then in 1993, in response to a number of high-profile nosocomial multi-drug resistant TB outbreaks. This is where people were placed on TB treatment for what they thought would be the regular drug susceptible TB. Isolation was discontinued after 2 weeks, but it turned out in retrospect that the individual had drug resistance and was not responding to therapy. And once the isolation was lifted, they went on to transmit to further contacts. And so in order to avoid these disasters or prevent these disasters from happening again, the CDC introduced a pragmatic step that said you cannot de-isolate someone until they've smear converted, which is a marker of responding to therapy, and or at least thought to be a marker of responding to therapy. But I think there's more to it than that. I'd like to share some of the data that guides, that informs this topic, and the Appendix B that's in the TB standards summarizes much of the data I'm going to talk about, and I also just point you to some other reviews that systematic reviews that others have also undertaken. So in respect of the hierarchy of evidence, we'll start at the top and move down. So with respect to clinical randomized controlled trial level data, we have one study only, which in infectious diseases, and I would think in infection control, is actually really good. We so rarely have randomized controlled trials to guide our practice in infectious diseases or in infection control. So, but here we do. It was conducted in what is now known as Chennai in 1957 by the WHO, the British Medical Research Council, and the the Indian Council for Medical Research. This was a large study. They had 193 people with tuberculosis, and they treated them. And at the time, the treatment was INH and PAS alone. But they randomized people to be treated in a sanatorium where they were isolated for the entirety of their treatment, or where they were just sent home on day one and to take their treatment in the community, to take the treatment at home. So they were specifically testing the hypothesis that once people are on treatment, they shouldn't transmit more to their contacts, and then you can de-isolate people right away. They also looked at whether nutritional supplementation would help TB, if keeping people housed would help TB. And so this study is well worth reading if you have a chance. But for us, we'll focus on the transmission outcome. They had an extremely high retention and care, and they had extremely detailed follow-up of these patients. And they found that there was no difference in TB incidence between household contacts of participants isolated in the sanatorium and those who were sent home right away. They looked at rates of TST conversion as well, test positivity, and those were similar between the contacts of each group. Some of the downsides, I suppose, that might compromise the results of the study, or might make people less willing to have to adapt to have to inform their practices, that at the time there was lots of TB in the community. So infection of contacts may have happened just in the community and may have obscured what might have been important differences in transmission. And then some family members would still kind of sneak into hospital, into the sanatorium, and be able to visit. That was acknowledged. This wasn't a jail. And so there may have been some crossover, and that may have limited our ability to detect some residual transmission. But in order to sort of examine that feature, a few years later, the authors reanalyzed their data, and they looked at, okay, what about those patients who were sent home and had very long persistent smear positivity? Did that predict transmission to contacts, the duration of their smear and culture positivity once on effective therapy? And they found that it did not. And so they concluded that once you're on TB treatment, once you start TB treatment, you're no longer infectious. That's it for controlled data. We do have some observational. Only one comparative study has been performed. This was done in an Arkansas TB facility. They looked at a bunch of people, 155. Some were de-isolated and sent home despite remaining smear and culture positive, and others were kept in isolation until sputum culture negative, and that was not randomized, that difference. But they did look back at transmission using detailed TST analysis and contact tracing, and they found that there was no difference in transmission and contacts between those who remained smear positive when they're de-isolated and those who didn't. A caveat here is that the de-isolation occurred on average about 4 weeks after treatment start, and so that made weaken the study for our purposes. Finally, the observational data, there's two non-comparative studies, a study out of Baltimore and Cincinnati. Both of them looked at patients with TB who remained smear positive and culture positive, but were treated at home without isolation. And they did detailed TST conversion and TST studies, and found they thought that no transmission occurred once people were started on treatment. And that was true in both studies. In the Cincinnati study, however, a lot of the children were placed on gap prophylaxis, which may have obscured our ability to detect important difference. So I don't know that these studies are definitive, but that's what we have. Moving down the hierarchy of evidence, we get to observational data. And in the era of COVID, I think this sometimes became our dominant part of the discourse. But in any case, looking at case reports, there is one case reported transmission occurring after TB treatment had started, only one that I could find, and I know a number of others have looked systematically and non-systematically, and we think there is only one reported case of transmission that occurred after TB treatment was started. This is one documented case, of course, and the transmission appeared to occur within hours of starting TB treatment. So this patient presented to hospital very sick with pulmonary TB, given one dose of Rifampin and INH, and then had a cardiopulmonary arrest and was coded. None of the healthcare workers attending to the code were wearing any PPE. And the patient was not in isolation, and there was no the air exchanges were not described, but probably were not what we would expect nowadays. And many healthcare workers acquired TB infection, and some even developed TB disease that was subsequently linked to this case. So it was a spectacular case, spectacularly bad. But it probably doesn't answer the question about whether 2 days or 3 days or 4 days of treatment would have prevented transmission. Just that at least 1 day of treatment is not enough. I've never been unable to find a case of TB transmission in any published or documented after 2 weeks of therapy. When we can't look at clinical data, we sometimes look at animal data, and TB, the history of TB is rife, has lots of guinea pig studies. Guinea pigs are exquisitely sensitive to tuberculosis. So if they, inhale even one airborne droplet, the guinea pig will develop in TB infection and usually progress to TB disease. So it's a very sensitive model for detecting TB transmission. And in fact, the reason we know that TB is transmitted through the airborne route is because of the original guinea pig studies conducted in the 50s in Baltimore by Riley. And just depicted on this slide is his original test chamber, where he took patients with TB on the TB ward, and the air from their rooms was exhausted to another room on the floor above, where he kept guinea pigs, and he was able to measure how infectious people were. And what he noticed in detailed studies over the course of 10 years was that that transmission in guinea pig stops within a day or two of initiation of effective treatment. And in this era, this was INH and PAS, although later studies confirmed it with Rifampin-based therapy, and even in multi-drug resistant TB therapy. It didn't quite stop. There was a very small number, 1 or 2 guinea pigs that were infected after patients had been on treatment within a day or two, but almost completely stopped. They couldn't answer the question of whether 1 week would have been enough to prevent transmission completely. But it was very fast decrease in transmission, very marked decrease in transmission to guinea pigs. Unfortunately, though, the studies can't give us information on the precise time after treatment start people become completely non-infectious. If animal studies aren't going to answer our question, we have to go down the pyramid even farther. And now we look at in vitro studies, and this is looking at cough aerosol sampling, which I think was a small niche of infectious disease medicine in the past, but since the COVID pandemic, this modality I think is really come back in vogue. It's fashionable now, and I know that there were lots of these cough aerosol studies going on in our province during the early course of the pandemic, the COVID pandemic. Here, though, we patients would cough into a specialized machine that would then capture the infectious aerosols and culture for viable organisms. And the notion here is maybe as people, maybe the bacilli that are living in the droplets, the infection, those air droplets get concentrated. The INH and the Rifampin and the TB drugs that are in the sputum that they've been excreted in the sputum become highly concentrated in these dried aerosolized droplets, and might prevent the establishment of infection in a secondary case. So using this cough aerosol sampling device, other people have looked at TB transmission. They find that cough aerosols predict infectiousness to contacts much better than just conventional sputum smear and culture. 2 cough aerosol studies have looked at people just starting treatment, and have found that that within just a few days, 2 or 3 days of starting anti-TB treatment, the number of culturable bacilli in the actual aerosol droplets declines rapidly, even as the patients remain smear positive and even as they remain traditional sputum culture positive. We don't have studies that look precisely, again, is 1 week enough, is 2 week enough, but it does appear from these studies that the infectiousness disappears within days, or at least the presence of of culturable bacilli from aerosols is gone within a few days. So just a review of the evidence. There's few clinical studies. There are none that are recent. All of these studies, of course, are very before my time. I think it's fair to say that there are more review articles than there are primary studies on this topic. So there's lots of reviews, including my own, that summarize this handful of studies that I've just shown you now. The guinea pig and cough aerosol studies, I think, are promising and I think are quite convincing, just given how sensitive those tools are. But unfortunately, they don't precisely determine how quickly people become non-infectious. That said, I do find the data very convincing that sputum smear does not predict infectiousness once you're on treatment. Of course, pre-treatment, it's a crucial indicator of infectiousness. But once you're on effective therapy, and that's crucial that it's effective therapy, and that the sputum smear, I would say, is no longer relevant for predicting infectiousness. So what about the other side of the equation? We've talked about how treatment renders people non-infectious and how long people might need to be on isolation for. But there's another component to that, and that's the potential harms of prolonged isolation. And there is some literature to guide this question as well. I think there are lots of studies now demonstrating that isolating patients for TB when they're in hospital has been associated with significant anxiety, fear, and mood dysfunction. One of the researchers in our province did a qualitative study looking at some of the experiences of Indigenous people who were brought down for isolation because their communities could not support isolation in their homes, and it can be traumatizing, frankly, to keep people isolated. And the longer the isolation goes, the more mental health impact there is. This study just cited below by Dr. Basham in Vancouver sort of really documented really well that the longer patients stayed in isolation, the more likely they were to be depressed. And there's almost a direct correlation. And so I think there's real benefits to shortening the time to isolation if we can. We also know that people under isolation have less visitors than other patients. Looking at patients under isolation for MRSA and C. diff associated diarrhea, that they get less visits by nursing staff, less monitoring. We know that qualitative studies in MDR-TB patients indicate a strong preference of family and the patients to be de-isolated as quickly as possible. This is important. Like, you might think that family members who are at the most risk of getting infected, if a patient was sent home while they were still infectious, you might think that they would want patients to stay isolated, but that's actually not true. Most family members are actually quite okay with people being de-isolated earlier. We also know that providers feel obligated to intensify therapy to get people smear converted more. I know in our province, it's common to just add on a quinolone with its attendant toxicity to the patient, just in an effort to try and speed up that smear conversion process, even judging that the benefit of de-isolating earlier outweighs the possible side effects from quinolone therapy, which are legion. And then also in our province, in order to detect exactly when smear conversion happens, we're often doing sputum samples almost every day just to get people out as soon as possible. So what are some of the implications for policy? We had a large policy discussion our goals were to balance that real tangible harms of prolonged isolation of persons with TB, but also that responsibility that if we know someone has TB and there's a way to prevent avoidable transmission, we are obligated to do so. We want to prevent that. So we wanted to find that balance. We know that I consider this a bit of advocacy for people living with TB to help them get de-isolated, especially, and I think that's especially important because so many people with TB have other health issues or other social issues. They often from otherwise marginalized populations. And so I think if we are over de-isolating or keeping them isolated too long, in some ways that's bullying or traumatizing if it's unnecessary. And so I do want to advocate for them, but we also must remember that the people, when they go home, if they were still infectious, the people they'll transmit are also members of their community and would also be from marginalized communities. So I think both sides are important here. And then we hoped with this policy to achieve an agreement on exactly when the point is where transmission after treatment start is in fact negligible, and when isolation is no longer justified. So our initial policy was, let's just go back to the 2-week rule and then just have some provisos and extend the isolation a little bit longer if there were certain extenuating circumstances. That's what I hoped would happen. But what actually happened is we had to acknowledge in multiple policy discussions that our evidence is imperfect. I've just described it to you. It's not 100%. There's always weaknesses that can be found. And just because we can't prove that transmission has happened after treatment is started, or after 2 weeks of treatment, doesn't mean it can't or won't ever happen. It's always harder to kind of prove the negative than it is to prove the positive. We also encountered this phenomenon that even though the original policy on prolonged isolation wasn't really direct evidence, it was a pragmatic decision, that any time we wanted to change that policy, it was felt we needed very robust evidence. And I think that's true in many areas of ID anyway. We're trying to always shorten antibiotic courses or get people onto oral therapy, and we meet lots of pushback, even though the original need for high dose IV prolonged therapy is not based on high quality evidence either. It's just that changing policy seems to be harder than implementing it. Policymakers were also very cautious. We know that there's a lot of medically immunocompromised people nowadays. We also know that we have whole genome sequencing now. So if anyone gets TB, we'll know exactly where it came from. And so it'll be proven. And if an infection control officer or practitioner de-isolated too soon and someone got TB, it could be proven, and people would feel very badly about that. And then finally, I think policymakers wanted us to develop guidance that was direct, generalizable to all cases, usable by non-experts, even usable by ID docs like me. So plain and simple. And so what we ended up landing on, maybe some of you will have read this already in the standards. We think, and so I'll just go through these very quickly. If you're smear negative, rifampin susceptible pulmonary TB, we think you should be isolated for 2 weeks, and then of effective therapy, and then isolation can be discontinued, provided that they're tolerating the therapy and they're taking it. For smear positive cases, rifampin susceptible, this is the group that we were really hoping to shorten duration of therapy, or at least I was hoping to shorten duration of therapy. We landed on a minimum of 2 weeks of effective therapy and sputum smear conversion, but as an incremental change, as a win for incrementalism. We said, if you remain sputum smear positive after 4 weeks of effective therapy and you've responded to treatment, you're getting clinically better, that isolation precautions may be discontinued, whether you're in hospital or whether you are in a high-risk setting or not. We would consider you non-infectious after 4 weeks of effective therapy. For drug-resistant TB, MDR or rifampin resistance TB, we do still, the new standards suggest that certainly you'd be consulting with a TB expert in this case as well, but we hope that once you have confirmed susceptibility to the agents that you're using to treat the multi-drug resistant tuberculosis, they've had 4 weeks of effective therapy, and that they've achieved sputum smear conversion. So in the old standards, you had to achieve culture conversion. Many of these patients would be on isolation for 2 or 3 or 4 months. So I think this represents significant shortening. This would be about 1 month of isolation for patients, rather for MDR people with MDR TB, rather than the 2 or 3 months it was before. There's a few caveats. We really in Alberta are really trying to emphasize home isolation wherever possible. Unfortunately, when home isolation isn't available, it's usually in people who don't have homes, or people who live in congregate living settings, often vulnerable populations otherwise. We also have to make sure that there's a good treatment plan in place. You can't just discharge them from hospital and then nobody is around to give them treatment at home and they just rapidly become infectious again. It's important to realize that they have to clinically improve, and you have to have some notion of drug susceptibility before you send them home. So getting back to those original questions from the case, it is not known exactly when someone on effective TB treatment is no longer infectious. But I think the preponderance of data suggests that it occurs quickly. I think it probably occurs within a few days based on the sort of a detailed reading of those previous studies and the guinea pig studies. But I think almost certainly patients are non-infectious after 2 weeks of therapy, even if they remain smear positive. I think the sputum smear status, once patients are on effective therapy, is no longer predicts infectiousness. I think that's kind of a common theme, a common part of our infection culture, I think, that if patients remain smear positive, that they must still be infectious. But I don't think that's true. I think they're often excreting dead bacilli, or bacilli that are no longer infectious. And I think the data supports that notion. I think that creating and implementing de-isolation policy is hard to do because we don't have definitive data. We don't have a clean randomized controlled trial, but in a low prevalence setting. But I think it's still important because I think these people living with TB have to share, the burden, or they're the ones that shoulder the burden rather, with prolonged isolation and the attendant adverse effects. I'm grateful that we achieved some incrementalism with the new guidelines. I know there was significant anxiety about that, but I'm grateful that we at least shortened it a bit. I also just wanted to point out, this is a picture that one of my mentors and teachers, Dr. Jaffe, provided me a long time ago. It's not our case, but this is, I think it's representative. This is a case of what was eventually found to be smear positive pulmonary tuberculosis. But they came into hospital with cough and fevers, and it was felt to be a community-acquired pneumonia. So they were started on amoxicillin and then admitted to hospital. And in my hospital, beds are in short supply, which I think might be an issue in your setting as well. And so we often have to admit, many people into one room. Of course, I think this is probably universal across the country. On this particular scenario, there's an extra bed they just kind of stuffed in the side of the room. So there's one on the other side. So what was meant to be a 4-bed room is now 6 beds. And I know that there are curtains in between all of the beds, but as everyone here on the call will know, curtains won't prevent the transmission of tuberculosis, unfortunately. So this man had TB, of course, and for several days until it was recognized. And so we often focus on whether we can become quite anxious and over-focused on people with known TB who are on treatment and are isolated. But really, much of the transmission that we're seeing in hospital occurs because we don't recognize the TB in the first place. So that's I think that's an important point to be aware of. So I wanted just to thanks everyone for listening today and giving me the opportunity to speak to you and go over this important issue. And I wanted to leave enough time, ample time for questions and comments. And so I'm going to end a little bit early. But before I do, I just really wanted to thank some of my teachers and mentors, and Dr. Dina Fisher in Calgary, and Richard Long in Edmonton, Dr. Ray here in Toronto, in Ontario, who many of you will, I'm sure, know, and then Dr. Johnson, Dr. Menzies, and Dr. Johnson here in Ontario, or in Canada, for discussing these guidelines with me back and forth, and coming up with something we could all live with. I don't know. I'll stop now, and I'd be happy to answer any questions or further elaborate on any points.
So thank you so much, Dr. Cooper, for walking us through so eloquently the relevant evidence here, not only about duration of infectiousness, but also about impacts of prolonged isolation. Thanks also for the window into some of the thought that went into translating this evidence into the updated Canadian TB standards recommendations on de-isolation, and also for highlighting some of the caveats to keep in mind. So with appreciation for your more didactic portion of the session, we'll move into the Q&A. I am encouraged to see that we do have a few questions already, but certainly welcome others who may be thinking of a question to share it in the Q&A pod, because if you're thinking about it, others are probably wondering as well. And we have the advantage of having Dr. Cooper here to speak with us for a little while longer. So I'll start with the first question in the Q&A chat, which is, how common is it in practice to deviate from the Canadian TB standards recommendations regarding de-isolation based on individual clinical expertise? So that could be a question about past practice, as well as in the era of the fairly recently released updated recommendations. And welcome your thoughts, Dr. Cooper.
Yeah, thanks for that question. That's a good one. I have to say, in Alberta, at least for most TB patients, there isn't a lot of deviation from the standards, or at least there shouldn't be. All the TB cases are managed through a centralized TB program. So once a case of TB is identified, Their management is taken over by the TB public health team. And so if they're outpatients, they are only lifted from isolation if that's been approved by one of the handful of TB physicians in the program. And if they're inpatients in a hospital setting, they would be de-isolated only. They would also have a TB physician following them. And, infection control practitioners would only release the de-isolation if they met these criteria, which we have shared with our infection control team. Now that it is true that we have had times where we might extend someone for isolation. Despite the fact of my confidence, if I felt someone was going to be discharged to an unstable situation where I couldn't be confident that they would get TB treatment, we might keep them on isolation a little longer. That has happened. I can't say we've ever shortened off isolation, gone shorter than the guidance is described. So. But I imagine that happens all the time, and I know in America, I don't know that everyone follows the American guidelines either. I'd be interested to hear what happens here in Ontario, but we benefit from that centralized program. And we're rule followers here in Alberta. That might be obvious.
Thanks so much for that answer. I'm going to ask a related general question about the Canadian TB standards and their implementation. So it's a question about, since the publication of the updated 2022 8th edition of the standards, are you aware of Canadian or other jurisdictions that have changed their policies or approach to de-isolation?
I'm not aware. I know that in America, that they're working very hard on this, trying to implement something similar. So I do, and I know in California has already shortened time to duration. I did not have time, but I could share those slides. They're included in the TB standards appendix. But I did do a survey of what other jurisdictions outside of Canada are doing, and although America and Canada have, for the most part, are sticking with smear conversion. It's noted that England and Australia, New Zealand, and California have all embraced a shorter duration of isolation, usually something like a 2-week rule with various caveats. So I don't think Canada would be leading the way. I think other jurisdictions have already gone that way.
Thanks so much. I am scanning the questions and trying to group some themes together. So I'm skipping ahead to a question about potential impacts in terms of thinking about hospital IPAC policy. So the comment is, thanks for the excellent rounds. And in terms of hospital IPAC policy, can you let us know if there are any examples of exceptions to the de-isolation policy in your policy? Are there examples where you would feel uncomfortable?
Yeah, I'm increasingly comfortable, but I suppose I always give the example to residents. I do think that de-isolation should not be a rote sort of algorithmic decision. And so we struggled a lot with that in making these guidelines, that there was a real strong push to have something concrete that people could use to communicate, that people could refer to. But we also recognize that sometimes we worry that someone isn't responding to therapy, that maybe there's some reason they're malabsorbing drugs, or maybe they have or they're not taking them, they're cheeking them, or something is happening. And so we all, like in my practice, I would always review those cases to confirm for myself that they are taking the treatment, that they are susceptible to treatment, or that highly expected to be susceptible to treatment, that they are responding. And so I would hate for people to just de-isolate mindlessly. I do think it should be reviewed by an infection control practitioner. And in our setting, it's always reviewed with a TB specialist, just to confirm that we're okay. So I guess that's a danger of having a black and white recommendations, that people might think, okay, well, they're still coughing up and they're still febrile and they're barfing up their medications, but I'm de-isolating because it's 4 weeks now. That's not the intention. This has to be a deliberative, thoughtful decision with some expertise, either an infection control practitioner or in consultation with a TB specialist, would be my opinion. In In the past, you might be sensitive if they were to be discharged to a solid organ transplant ward. So if you stopped isolation and then the next available bed is a group of 6 patients with solid organ transplants, I think many of us would employ an overabundance of caution. Thank you.
Thanks. So a different kind of question about the Canadian TB standards recommendation is about the focus on considering rifampin susceptibility in these de-isolation recommendations as opposed to isoniazid monoresistance. So the question is, what if the patient has isoniazid monoresistance? What brought you to the decision to specifically include rifampin and not INH resistance in the recommendations?
Yeah, thanks for that question. And if I'm correct, I think that's coming from Dr. There was a lot of discussion, and I think it was in part driven by Dr. Ray and other members from Ontario about the notion of INH. And so we had lots of debate about that, especially since much of the early literature showing de-isolation was with INH, the clinical literature. There's lots of guinea pig studies and cough aerosol studies with rifampin now. And so that was much debate. It was felt that if you're on rifampin, a rifampin-based regimen, that we would consider you to have reached that threshold of negligible infectivity after the 2 to 4 weeks, provided you're responding otherwise. And so although previous iterations did have stipulations around INH, those in the final draft were removed. A lot of that is also informed by in vitro early bactericidal assays showing that rifampin has close to the same bactericidal activity, early bacterial side effect of INH, even if it's not quite as quick.
Thank you. We have a couple of questions that ask about the potential for a role for local platforms such as GeneXpert in terms of susceptibility testing. So I'm sort of paraphrasing, but wondering if you could speak to that general issue.
Yeah, and it might be worthwhile to hear from Dr. Greenblatt as well on the availability of that. But yeah, so we're fortunate enough to have the expert platform, that PCR. I know that Ontario also has a rapid genotypic testing. I believe using the line probe assay to rapidly detect resistance. And so we have really used that to inform treatment. I think I would consider the standard of care for effectively treating a patient with TB to have rapid ascertainment of rifampin susceptibility at the very least, and if you're fortunate, rifampin and INH as soon as possible. So even if we have a smear negative case, we will perform PCR to look for genetic resistance determinants on the biomass, so we can know within a couple of days of starting treatment whether it's rifampin resistant or rifampin not. I do think that should be the standard of care. I think waiting for phenotypic drug susceptibility testing, which can take several weeks, I think is inappropriate in Canada. Sorry if that offended anyone.
So I think you've answered a question about the speed of getting rifampin sensitivity results in Alberta.
Okay.
I'll maybe move on to a question also about laboratory testing regarding whether there are any concerns about sensitivity and specificity of direct from specimen NATs surrounding rifampin performance that would lead to false reporting of rifampin resistance or susceptibility.
Okay,
so
these are great questions.
Yeah.
Yeah, the excellent questions. Yeah, so for smear positive samples, of course, we've found the sensitivity. I think the question was specifically around rifampin sensitivity, so I'll speak to that then. So sorry, yeah, the rifampin, if it's not detected, we find the ability to exclude rifampin drug resistance to be extremely good. We have that's reported in literature. In our experiences, we have not found a rifampin drug resistant case that was susceptible, that was considered genotypically susceptible. The other way, though, is not true. We do find that we get an expert back positive, says there is rifampin resistance. We start them on second line therapy only to find out that they're phenotypically susceptible. So there's that discordance between genotypic resistance and phenotypic susceptibility. That's irritating and obnoxious, although I think emerging literature is starting to suggest that maybe those individuals don't respond as well to rifampin-based regimens, that maybe there's an elevated MIC to rifampin that's still below the critical concentration, but is nonetheless might behave like a rifampin drug susceptible TB. So I think that's an area of active research, and I won't go much farther than that. But yeah, it is correct that sometimes we get false positives with rifampin resistance, or what may be false positive rifampin resistance, and we have to explain that to the patients, which can be awkward.
Okay, thank you. So reassuring in terms of sensitivity, but different considerations about specificity.
Yeah, and from an infection control perspective, I think we're making the error the correct way, but but yeah, no, there's concerns there, and I'm glad someone mentioned that.
Great. I'll ask a few more laboratory or testing oriented questions. Is there value in retesting smear positive patients with rifampin susceptibility with sputum smear at 4 weeks if they were still positive at 2 weeks, or should they be automatically cleared? So I guess this is about the combination of time plus consideration of smear status.
Yeah, so what we tried to highlight was before 4 weeks, if you were clinically getting better and you smear converted, you can be deisolated. But once you've reached the 4-week mark, you're classified as persistently smear positive. And if you're responding to treatment, we think that sputum, we would judge you to be non-infectious at that 4-week mark. And that we consider that abundantly cautious from our experience and from the literature.
Thanks. So related to duration, how long does it typically take to identify MDR or XDR TB to help guide these decisions?
Yeah, so again, speaking back to those those tests regarding PCR, whether it be the line probe assay in Ontario, or whether it be the Gene Expert in Alberta, we can usually get those results within about 48 hours from sampling the sputum. Much of the time delay is getting the sputum. Then there's another time delay getting the sputum to the provincial laboratory, and then there has to be processed, and then PCR has to be done. We can speed up that time by request. If we highly suspect TB, we just actually request PCR up front, so it can be done at the same time as the smear. And so we can sometimes shorten that. We can also request stat processing, although that's burdensome on the laboratory. But so on average, about 48 hours. But sometimes we can shrink it down a little bit farther if necessary.
Thank you. So we have a question about the scenario in which you don't have your genotypic susceptibilities available and the culture is not yet available yet. So what are the recommendations, presumably in the Canadian TB standards, in this scenario for de-isolation?
Sorry, I was also
no worries.
reading, so could you repeat that question?
I'll repeat it. It's what is the recommendation for de-isolation if the genotypic sensitivity testing is not available and nor are the culture results available yet?
Yeah, so one of the reasons we chose the 2-week minimum, because actually for a while in Alberta, if you were a smear negative case of TB, we were de-isolating very rapidly within a few doses of TB treatment. That's consistent with what happens in other jurisdictions throughout the world. And so we were doing even more rapid de-isolation in Alberta of smear negative cases. But the reason we used a minimum of 2 weeks for the smear negative cases, because that's how long it would take one of those cases to eventually get phenotypic culture-based drug susceptibility testing. For smear positive cases, it takes on average about 4 weeks. And so then again, that's why we chose that maximum of 4 weeks. So even if the there should be enough time to allow for that phenotypic confirmation of drug susceptibility. Because you're absolutely right. If the patient has a cult drug-resistant TB and they're on treatment that's ineffective, then they will still be infectious. It is effective treatment that renders them non-infectious. And that's why the MDR de-isolation guidelines are much more cautious, much longer isolation.
Yeah, thank you. And I think you nicely articulated that in the slide in the presentation. There is a question about subpopulations. So how well do these studies that you've reviewed for us today translate into more niche populations when exposed to TB clients while in treatment? For example, immunocompromised patients and young children under the age of 5. In other words, are we still confident in shorter isolation policies for certain groups like those mentioned?
No, those are great questions. So the guinea pig studies, I think, inform that, and that they're extremely sensitive to tuberculosis, and I think represent a particular a model that allows us to be sure that it's not that transmission, even with a handful of infectious quanti, has not occurred, and I think might inform these highly susceptible populations. I think the tuberculin skin test conversion studies measure infection, not just progression to disease. So immunocompromised patients, of course, would be prone to progressing to disease, but we think that deisolation after 4 weeks is not even resulting in transmission or infectious aerosols or infection in guinea pigs. So it's we still think it's safe even with highly susceptible populations. Although, yeah, I know there's anxiety around that, so I appreciate the question.
So we have a comment and some questions about the Alberta experience today, given that you've sort of gone ahead into the realm of shorter isolation periods, and just wondering if you can speak any further about your experience so far, and if there is any evidence of missed transmission or rather missed infectiousness, and any role for whole genome in trying to monitor that.
Yeah, lots of great questions. So our experience, so Edmonton has been using this policy probably for, in Edmonton, maybe 2 or 3 years. And so far, so good. We have not seen transmission post-treatment initiation. It's hard to detect, of course, because most of the contacts will have been exposed prior to treatment initiation and prior to diagnosis of TB, but we have not detected that. I know Calgary, one of my teachers and mentors and heroes, Dr. Dina Fisher, has been employing a strategy more aggressive than the one we're using now for years, possibly up to at least 10 years, and has not seen a transmission post-treatment initiation. So we have lots of experience, but again, we're always left with that. We probably at this time don't have absolute 100% certainty, but I don't know that that's the goal. I think we need to come to a point where we reach negligible risk of transmission and that is no longer justified. And I think these guidelines find that point. The second piece of that question is what further study might happen and whole genome might help inform these guidelines or test these guidelines. Short of a large randomized control study in a low prevalence scenario, I do think whole genome sequence analysis is a great way to test this. We've just started that as of January. We're now doing universal whole genome sequencing, and so I think that'll give us a huge amount of data that we can use to test this protocol and see if we are finding transmission that can't be explained by contact prior to treatment initiation. So.
Thank you so much for sharing that. And I have a related question that highlights the different contexts in Alberta where you describe the centralized TB system as opposed to a province like the one we're hosting the rounds from, where we might have a range of managing clinicians. And you've also noted the differences in terms of the laboratory testing that's currently in practice. So for example, now not including all that sensitivity information here. So just wondering if you can comment on, I suppose, translating the practice change in the context like your province to ours.
Yeah, so the lack of NAT testing, I think, hopefully will have some impact. Obviously, I think that's I understand it to be a temporary problem, and I know that there are extraordinary circumstances. So I would hate to have a policy that that assumes that accepting the lack of nucleic acid implication is okay. And I know it's not, but I do also think that there's room to wait until you have phenotypic drug susceptibility testing results. And I think if you don't have NAT, you have to wait for those. At least to confirm rifampin susceptibility. I know some jurisdictions in Canada, or not some TB physicians I've spoken with, if the risk of drug resistance is extremely low, they might feel confident in de-isolating early. I know that has happened. So there's some if it's a case of TB where it's known to have occurred in close contact and the source case is fully susceptible, some people make that judgment, and I wouldn't stop that. But as a rule, at least for our purposes today, I think you have to wait for phenotypic drug susceptibility testing.
Thank you. I know we're almost at the hour mark, and we've tried our best to get to as many questions as possible, but I am really just on behalf of PHO, I just want to say thank you so much for sharing your expertise today, for generously participating in the back and forth with our virtual participants who asked so many excellent questions today. Want to remind our attendees that you will receive an evaluation shortly, and we, as always, appreciate your feedback to help continue to inform our rounds programming. And just want to echo the many comments I can still see in the Q&A chats of thanks to Dr. Cooper for a really excellent presentation and session today.
Thanks, you guys. I appreciate it.